Great. Hello, everyone, and welcome. I'm Garnet Henderson, the host and producer of Access, a podcast about abortion. And with me today is Dr. Meera Shah. Dr. Shah is the Chief Medical Officer of Planned Parenthood Hudson Peconic, and she's also the author of a new book called You're the Only One I've Told, The Stories Behind Abortion. Dr. Shah, thank you so much for joining us today.
Oh, thank you so much for having me. I'm excited to be here.
Great. So I know that you're a family medicine physician. You provide abortion care as part of a large spectrum of care that you offer to your patients. So could you just start by telling us a little bit more about the kind of work that you do?
Yeah, so I am a board certified family medicine physician, but I specialize in sexual and reproductive health care. So I provide prenatal care, abortion care, contraceptive care. I do cervical cancer screening, breast cancer screening. I also provide vasectomies, as well as hormone therapy for the transgender community. HIV prevention services such as PrEP, PEP, and we're about to launch the rapid initiation of ART, which means that on the same day that an individual is diagnosed with HIV with a rapid test, we will initiate antiretrovirals that very same day. So I provide the full gamut of services, and we keep up with science. So as things evolve, as things change, we are very quick to adapt our protocols to make sure that we're providing the most evidence-based, patient-centered care.
Great. And did you enter medical school knowing that this was the kind of doctor you wanted to become?
Absolutely not. I always knew that I was going to work in public health and work in social justice, but I didn't know what that would look like until I became a resident and had an incredible mentor who really introduced this idea that abortion is normal. I was just so intrigued by how she worked so hard in her career and in her practice and in her teaching to normalize abortion, just portray it as, this something that can be offered in an outpatient setting, and as, just as good of an option as someone who chooses to continue a pregnancy and become a parent. She really set an example for me in my career. And I was just also so intrigued that politicians are constantly trying to prevent access to such an important and vital service. And so not only do I provide direct patient care, I also advocate for my patients at a state and national level in any way that I can. Whether it be advocating for certain policy or speaking out and trying to decrease stigma around abortion and sexual health.
Mm-hmm. And what kind of attitudes around abortion were you exposed to growing up?
So great question. I grew up in South Carolina. I'm the daughter of Indian immigrants. We didn't talk about sexual reproductive health. We didn't talk about sex. I come from a family of physicians, but because of my culture, that just is not something that we talked about. And it wasn't until I started doing this work and started becoming more open about it that I introduced the exact nature of the work that I do to my parents. And because I presented it with such confidence, and I have a really good relationship with my parents, and they trust me, and it was actually a really smooth introduction to my day-to-day. They were really accepting and open, and through storytelling, I've been able to really gain their support. So I care for people from the Indian community at one of my health centers. So one of my health centers is located in Long Island, and there's a large Indian community in that area. And they come to see me because I speak their language. I just started out as one or two patients, but then word got out. And, anytime I care for somebody who is of Indian descent or somebody who's Gujarati speaking, I tell my mom, and my mom just is like, oh my gosh, Indian people have abortions. And I'm like, yes, mom, Indian people have abortions. And just this, it was something she could relate to. Something she could identify with. And now and I don't mean to suggest that she wasn't in support of abortion access before, but now more than ever, she is, like a little activist in her own right. And she talks about it. She talks about it with her girlfriends. She read my book. And so I truly believe that through storytelling, we can change the narrative around abortion.
And so, speaking of storytelling, you have a new book out. So tell me a little bit about the book and what made you want to write a book about abortion.
So, I've always loved reading and writing, and this is something that I've wanted to do for a really long time, is to just be a more consistent writer about things that I believe in, things that that topics that I work on in my daily practice. So I really just a few years ago started to put pen to paper and started to write. And I also felt that my work was really misunderstood, even among my social networks. I surround myself by a lot of smart people who claim to be progressive and vote a certain way, but they also just didn't know much about abortion, or would kind of unknowingly use stigmatizing language around abortion, like abortion shouldn't be used as birth control, but I believe in abortion. Or and a lot of that just stems from myths, or stigmatizing headlines, or just not really understanding some the sexual reproductive health at a deeper level. And so I wanted to change this. And so I started to write stories, and I made a really deliberate effort to highlight the stories of a diverse group of individuals, because I hear often that young people are the ones who get abortions, or or just straight up ask me, what is your typical, who gets abortions, what does that look like? And my answer is always the same, it's everyone, right? And so I tried to make that clear in my book by highlighting just the diverse makeup of people who get abortions, or who are impacted by a loved one having an abortion.
Yeah, I mean, that's exactly why I wanted to create the podcast, right? Because I found the same thing in reporting on reproductive health and abortion access specifically. Well, first of all, that those two things are often very separate. Like, there's the rest of reproductive health, and then there's abortion. And it's something that people just don't want to talk about, including people who consider themselves supportive of the right for someone to get an abortion. Because, abortion is constantly in the news, it seems, except so often we're talking about it without really talking about it. And in particular, there's often just a big flurry of attention, especially when a really restrictive law is passed or enacted. But so often we're not connecting policy to people and talking about how those laws, those bans actually affect people's lives. And that is why I think personal stories are so powerful. But it can be really difficult for people to tell those personal stories because of abortion stigma, because they're worried about their family, other people they know finding out. They're worried about harassment and threats, because that is also a serious problem. So tell me a little bit about how you went about connecting with the people whose stories are featured in your book, because it is all personal stories. So tell me a little bit about how you found those people and what your conversations with them were like.
Yeah, so none of the storytellers were my patients. One individual was, but by the time I interviewed her, she'd actually become a colleague. And so most of the people in the book are people who just kind of organically told me their story. And then I went back to them maybe a few years later to say, I remember a few years ago, you shared your story with me. Would it be okay if I did a more in-depth interview with you and included your story in the book? And everyone pretty much said yes. I also had colleagues connect me to people who they knew who were interested in sharing their stories, or friends who connected me. It just, I ended up having more stories than I was able to fit on the page, because I did have a word limit, but I really did get an overwhelming amount of interest in sharing stories. And I really wanted to address all the different sort of tangential stories and topics around abortion. So like later abortion, self-managed abortion, and get at who are these people, and let's stop talking about abortion as like this thing that happens to them in isolation. Let's talk about all of the intersections of that human being and what makes them them. And then what I found was that, and not surprisingly, that each story was layered also by political interference, right? So like there was each story was littered by like restrictions and laws and rules, and so it can't just be, unfortunately, at this point in time, your abortion story can't just be about like your individual experience as a human being. It has to be about like the setting in which you're in. And so I wanted to highlight that too, to make the point that there's so much interference. The politicians are basically in my exam room. Even though I practice in New York, there are certain things that I have to do that, that don't make sense, but I have to in order to comply with the law.
Yeah. Can you give just one or two examples of things like that you would not necessarily choose to do as a physician, but that you have to do because it's required?
Yeah. So, for example, in the electronic medical record, there's a federal law that requires that we have to write exactly the technique that we would use or not use for that abortion. So like, it's something that stemmed from the partial birth abortion ban,
right?
Where I have to say, that I used a certain technique, or I didn't use this certain technique in order to do that abortion. And okay, there's really no point. There's no point to that.
Right.
There's also, I fly to Indiana once a month to provide abortion care, and I have to read a script to the patients that say that, abortion can cause mental health issues. Well, that's not true. Yes, abortion is a life event. And so in that sense, like buying a house, having a child, having an abortion, things that are like big deals in people's lives that like can trigger emotion, experiencing a death in the family. Like, yes, it's a life event that can, have a downstream effect in terms of the way an individual processes it. But it doesn't consistently cause anxiety, depression, PTSD, as the anti-abortion folks say, yet I have to say that to every single patient. Or in Texas, I have to say that abortion causes breast cancer, which is not true. So yeah, there are a lot of things that I have to do that don't make sense, are not medically indicated, aren't medically sound, but in order to comply with the law, I do it anyway.
Right. And to your point about partial birth abortion, in case anybody doesn't know this, that is a federal law that George W. Bush signed into law. It was vetoed by Bill Clinton. And partial birth abortion is not a medical term. And so that law caused problems because it was passed and then signed into law by the president, but it doesn't actually have a specific medical meaning. So it was not exactly clear what is being banned. So when you say that you have to say, I did not do a partial birth abortion, that's a partial birth abortion is not a thing that you would do.
Right. It's not a thing, such as Late-term abortion, that's also not a thing. That's something that the anti-abortion folks made up. It's not a medical term. You wouldn't find it in any sort of medical textbook at all. It's just stigmatizing language. It's actually really triggering. I mean, that phrase, partial birth abortion, yeah, that triggers emotion.
Absolutely.
And it gets people listening. So for other reasons, it brings about attention, but for medical purposes, it's just a waste of time.
Right. And so the first episode of the podcast, which people are going to hear after our conversation, features you explaining what actually happens during the most common abortion procedures. And the reason I wanted that to be the first episode of the podcast is because a lot of people really have no idea, unless they've actually had an abortion, how it really works. And so I wanted to include that. And I'm wondering if there are some really common misconceptions about abortion that you tend to hear from your patients when they're coming in.
Yeah, well, one of the biggest things that I hear is just, it's almost like, I mean, they don't have to say it, but I know that what they're thinking is that, they feel really bad or they feel alone in their experience. So the underlying message there is that it's not common. And so what I do immediately is let them know that what they're experiencing is very normal. It's very common. 1 out of 4 women in the United States has an abortion in her lifetime. And I literally see their shoulders drop and like a sigh of relief that like, oh my gosh, really? Like that many? And the reason that they don't know is because people just aren't talking about it. That abortion is dangerous, when in fact it's one of the safest medical procedures that we do. That abortion will affect future fertility. In fact, the truth is that it does not impact future fertility. So yeah, these are the things that I hear and that I'm constantly, correcting and telling people the truth about.
Mm-hmm. And abortion has been a topic in this presidential campaign, as it sort of always is. And it's also on a lot of people's minds because of the nomination of Amy Coney Barrett to the Supreme Court, a judge who is thought to be someone who will vote to overturn Roe versus Wade, or at least further limit abortion access. So I'm wondering if you ever hear anxieties about those political events from your patients. Do people ever come in worried that this is a right that they're going to lose soon?
Yes. And if not from patients, definitely from colleagues, from friends, just the communities that I'm that I work in, that I socialize in. Yes, there's a lot of anxiety around this because she, becomes the next judge, then, or she sits on the Supreme Court, that'll make the Supreme Court with the conservative majority, 6-3. And yeah, she would have a big hand in potentially reversing Roe v. Wade, which would then cause trigger laws to be put in place, or so to become activated, which means that in many conservative states, abortion would automatically become a crime. Mm-hmm. Whereas in states like New York, which is progressive, abortion has been codified in the health law, so it's viewed as a healthcare service. Mm-hmm. So it would be protected in places like New York. And what we would probably see happen is twofold. One, we would probably see an increase in people having to travel further distances than they already are having to travel to places like New York to get abortion care. But then again, only rich, likely white people would be able to do this. So it would worsen health disparities that already exist. So low income Black and brown people would be pushed further to the margins and would be, unable to access abortion care. And then there would be an increase in people having to access or pills online and manage their abortions at home. So it's a really scary thought. to see, to think about what could happen and what's in our future. But we're gearing up for the fight. So
I have one more question for you. The pandemic has been a really interesting time for abortion access because in some states it has become much harder to get an abortion. In Texas, clinics were shut down for about 6 weeks. Other states' clinics opened and closed because governors were banning abortion by executive order. But on the other hand, in some states, it's actually become a little bit easier in certain ways to get an abortion, at least a medication abortion. So I wondered if you could say just a little bit about what you've been able to do for your patients during the pandemic, especially because I know one of your health centers is in New Rochelle, which was an early COVID hotspot. So you really had to be on your toes.
Yeah. So, New York and the communities that I serve were hit pretty hard by the pandemic very early on. And so we had to change all of our health center protocols to adapt and make it so that our patients could continue to get care, because the services that we provide are essential services. Pregnancy related care, sexual health related care, the need for those things doesn't stop even in the midst of a pandemic. And so we moved to a telehealth platform for pretty much all of our services except for procedural abortion and prenatal care. Those patients were able to come into the health center to get care, but everybody else is receiving care via telehealth, including our patients who needed medication abortion. So we were able to provide the whole counseling component of the medication abortion via telehealth, and then patients would come to the health center to get an ultrasound if they really needed one, as well as mifepristone and misoprostol, which are the pills that induce the abortion. And this improved access greatly. We saw an uptick in the need for medication abortion during the pandemic. We still are seeing an increase in need. And it was really awesome to be able to continue to provide during these times.
Yeah. And anybody who is interested in that can actually hear all about it in episode 2 of Access, in which Dr. Shah also appears, as well as providers from Texas and Maine. So thank you so much for being with us today, Dr. Shah. We're now going to play Access episode 1, What Actually Happens During an Abortion. And I hope that if you like the podcast, you will subscribe. You can subscribe wherever you get your podcasts, and there are 3 more episodes that are ready for you to listen to right now. We'll also have a subscription link on the event page here. You can also find a link to Dr. Shah's book here if you'd like to check that out. And Access is an independent production. We're not supported by any media company. We rely on listener support. So there's also a link so that you can donate to the podcast if you're so inclined. It's really easy to set up a monthly or a one-time contribution. Follow us on Instagram and Twitter at AccessPod. And don't forget to check out the rest of the Estrogenius lineup. The festival runs through October 28th. Thanks, and I hope everyone enjoys. Welcome to Access, a podcast about abortion. I'm your host, Garnet Henderson. Abortion is common. In the United States, 1 in 4 women will have an abortion during her lifetime, and many trans men and non-binary people have abortions too. That means that you almost certainly know someone, and probably more than one person, who's had an abortion, if you haven't had one yourself. But abortion is something that many people just don't talk about, at least not outside the context of political debates. On this podcast, I want to demystify abortion. and give you the information you need to really understand the things you're hearing about in the news. So today, we're clearing up the biggest mystery first. What actually happens during an abortion? An abortion provider is going to guide us through, step by step.
My name is Dr. Meera Shah. I'm a board-certified family medicine physician, and I am the Chief Medical Officer of Planned Parenthood Hudson Peconic here in New York. I'm also the fellow with the Physicians for Reproductive Health.
Dr. Shah is also the author of a new book out this week called You're the Only One I've Told: The Stories Behind Abortion. According to the Guttmacher Institute, which compiles the most comprehensive statistics on abortion in the United States, the vast majority of abortions in this country, over 88%, take place in the first trimester, or the first 12 weeks of pregnancy. Over 65% take place at or before 8 weeks. So during this time, there are two options for someone who wants an abortion: medication abortion, which can be done largely at home, or an in-clinic aspiration abortion. We'll talk about medication abortion first. Medication abortion, often referred to as the abortion pill, is FDA approved for use up to 10 weeks of pregnancy. After its initial approval in 2000, it was a little slow to take off, but now its popularity is growing rapidly. In 2017, for example, 39% of all abortions in the US were done with medication. That's a 10% increase just from 2014. One misconception I hear a lot is that the abortion pill and the morning after pill are the same thing. But this isn't true, and here's the difference. There are two types of morning after or emergency contraceptive pills. In the US, these are sold under the brand names Plan B and Ella. These pills prevent pregnancy, primarily by delaying or preventing ovulation. They do not work to terminate existing pregnancies. Medication abortion does terminate pregnancy using different drugs. So here's how it works.
Medication abortion is a really safe way to end a pregnancy. It has a very, very low complication rate, like less than 0.5%. And it involves a series of pills. The first pill is called mifepristone, and what it does is it blocks a hormone called progesterone. So progesterone is needed for a pregnancy to grow and to continue. But what Miffy does is that it blocks this hormone, thus preventing the pregnancy from continuing. So Miffy will end the pregnancy, but then it's not until a patient takes misoprostol, 4 tablets of misoprostol, they can put them in the cheeks, so 2 in each side, let them dissolve for 30 minutes, swallow the rest, or they can insert the 4 tablets in the vagina. And what the miso does is it induces cramping and bleeding. It kind of organizes the expulsion of the pregnancy. So again, Miffy will end the pregnancy and miso will cause expulsion of the pregnancy. Miso alone will end a pregnancy. It's about 80% effective in ending a pregnancy up to 10 weeks on its own, but Miffy does improve that efficacy. Patients take the Miffy at the office and then they take the miso at home. Within an hour or two, they should expect to experience the cramping and the bleeding. And the worst of it is for the first few hours, and then it sort of trickles down, and then some bleeding for a few weeks until their body starts to regulate the monthly bleeding again.
Dr. Shah says that patients usually manage the discomfort from cramping with high-dose ibuprofen. That's Advil. A week or two later, there's a follow-up to ensure that the abortion is complete. This either involves an ultrasound or checking for pregnancy hormones with a blood test or a special type of low-sensitivity home pregnancy test. Lots of people choose medication abortion precisely because it's done at home, where they feel comfortable. And many abortion providers would like to offer medication abortion via telemedicine. But there's a whole patchwork of state and federal regulations that make this difficult. And our next episode is actually devoted to this subject. So I'm not going to get too deep into it right now. But I will mention that mifepristone, the progesterone blocker, is regulated under an FDA program called REMS. That stands for Risk, Evaluation, and Mitigation Strategies. It means that providers who want to prescribe mifepristone have to be registered with the drug manufacturer, stock it in their office, and dispense it to patients directly, among other requirements. So they can't just write you a prescription to fill at a pharmacy. This is despite a wealth of evidence that medication abortion is safe. In fact, even the former FDA commissioner, who was head of the agency when mifepristone was approved, has come out to say that these regulations need to be rolled back. In July, the ACLU did manage to win an injunction blocking that in-person REMS requirement due to the pandemic. So providers in some states have been able to start mailing the pills to their patients instead of dispensing them in person. But the Trump administration has asked the Supreme Court to reinstate that in-person rule, and state laws make things even more complicated. Like I said, our next episode is a deep dive into telemedicine abortion and the COVID-19 pandemic. So for now, we're going to move on to aspiration abortion. Dr. Shah is going to mention several medical instruments here. If you want to get a better idea of what they look like, we have a great collection of photos on our website by Robin Marty, who, among many other things, is the author of a book called Handbook for a Post-Roe America. So take a look at those photos at apodcastaboutabortion.com. Okay, like medication abortion, aspiration abortion involves cramping. So patients have a few different options for pain relief. They can take NSAIDs, like Advil or Aleve, and some patients opt for moderate sedation, which involves a low dose of a benzodiazepine or narcotic. Some health centers do offer deep sedation using propofol, which is the same sedative that would be used for a procedure like a colonoscopy. But for first trimester abortions, this is uncommon.
If the option is there, people tend to take it. So I think patients tend to choose the moderate sedation. But I will say it's interesting because a lot of patients are like, oh, that was so quick and easy. I don't feel like I needed that. That said, I never try to deter people away from getting sedation because if they want their experience to involve sedation, then I'm going to be totally supportive of that. Even with moderate sedation, patients, they're not out. It's not like general anesthesia. They're sedated. We've taken the edge off, but they're still able to follow commands and hear what I'm saying. So I'm guiding them through the process if that is what they want. If they don't want me to say anything to them, I will not say anything to them. But many patients I find do want me to guide them through step by step what's happening.
So now we'll get into the procedure itself.
So an aspiration procedure is very safe, very, very low complication rate. And what it involves is a patient having a speculum exam, just like when getting a pap smear or a pap test, locating the cervix. The cervix is the opening to the uterus where the pregnancy is. So the uterus has the pregnancy and the cervix is the entry point to the uterus. We use an instrument called a tenaculum to stabilize the cervix.
I'm interrupting here just to say that if you have an IUD, like I do, this might sound familiar because these are the same steps a provider takes when they're getting ready to place an IUD. And for anyone who doesn't know, IUD stands for intrauterine device. It's a contraceptive device that's placed inside the uterus, and in many cases, if a person wants an IUD, it can actually be inserted on the same day they have their abortion.
Anytime we're inserting or removing something from the uterus, we stabilize the cervix with an instrument called the tenaculum. And then we will apply some lidocaine around the cervix to numb up that canal, because similar to labor, we actually stretch the cervix to open a little bit so that we can then remove the pregnancy. And just that act of stretching the cervix with dilators can induce cramping. So we use different size dilators to stretch the cervix slightly open based on the number of weeks pregnant that they are.
Cervical dilators used for first trimester abortions are small, typically no larger than the size of a pencil or maybe your pinky finger.
And then you can use two different types of aspirators. One is a manual vacuum aspiration. So it's this plastic device that's actually used all over the world. It's cheap, it's easy to use, it creates a nice suction. They're a great little device. We insert a cannula into the uterus that corresponds to the number of weeks pregnant that the patient is. It's almost like a straw. and you insert that into the cervix, and then one end is in the uterus, the other end is outside of the body, and we attach the MVA to the other end. We release the suction, and then we remove the pregnancy. For patients who are more pregnant, and this is also a style thing, this really depends on the physician you talk to, because some physicians will always use the electric aspirator. Some will use the manual aspirator more than others. It really depends. But typically for people who are a little bit more pregnant, we will use an electric aspirator, so an EVA, where we put the cannula into the cervix. So one end is in the uterus, one end is outside of the body. And then we attach tubing, which is then attached to a machine that we turn on, and it creates more suction to remove the pregnancy. The whole process takes anywhere from 2 minutes to 4 minutes. That's really it. And then afterwards, we evaluate the tissue to make sure that we are confident that all parts of the pregnancy have been removed. Sometimes we'll have an ultrasound in the examination room so that we can get a picture of the uterus after it has been emptied. And then we monitor for bleeding. We always check to make sure that the patient isn't bleeding. Usually they're not. And then we take them to the post-procedure room and give them a snack and some ginger ale. If they just receive local sedation, meaning lidocaine around the cervix, they are just monitored for like 15, 20 minutes. And then if they have received moderate sedation, then we watch them for 30 to 45 minutes. And then their escort will pick them up.
This type of procedure is very commonly referred to as a surgical abortion. But many abortion providers are trying to move away from that. And here's why.
It's not a surgery. We're not cutting. We're actually using an opening in the body that already exists. I know when I'm counseling patients, they are oftentimes scared to choose the procedure because they think it's a surgery, because that's what it's been called for so long.
You'll also hear this procedure referred to as a D and C. Again, this is common, but it's outdated. Dr. Shah explains why.
D&C stands for dilation and curettage. So dilation, as I described, and then curettage, basically they used to go in with like an instrument and kind of scrape. We use the aspiration, the suction technique, just because it's really effective in removing the pregnancy, just that pressure. So that's why I'm using the term aspiration abortion. You'll also hear this called a vacuum aspiration or a suction abortion. They mean the same thing. Aspiration abortions are usually performed up until about 16 weeks of pregnancy, though this can vary a bit depending on the provider. After that, the most common abortion procedure is called a D&E, which stands for dilation and evacuation. D&E follows a lot of the same general steps as an aspiration abortion. First, the person having the D&E chooses the sedation level they're most comfortable with. Then their cervix needs to be dilated. And it needs to dilate more than in an aspiration procedure, so the process can take a little longer. Sometimes providers use something called an osmotic dilator, also known as laminaria or LAM for short. LAMs work by slowly swelling as they absorb water to dilate the cervix gradually. Medications may be used as well. Sometimes we'll give them miso, which I described is used for the medication abortion, because miso, what it does, it softens and opens the cervix. So we'll give miso, we'll insert LAMs to prep it and to minimize the amount of instrumentation we have to do of the cervix. And patients will sit with those inserted for some time to allow the cervix to open up. And then the procedure continues. And sometimes, and again, this is a style thing. Some patients will have that done the day before, and then they'll come in the next day. It really just depends on how far along they are. So once the cervix is dilated, the pregnancy is removed. And this happens a little differently than in an aspiration procedure as well. So typically after 16 weeks, there is no aspiration of the pregnancy. It's about removal with instruments of the pregnancy. The instruments used also vary depending on the provider, but generally we're talking about a small forceps, which is a grasping tool, and or a curette, which is like a very tiny spoon. Suction is often used as a final step. Once the provider is sure the uterus is clear, the patient spends some time in a recovery room and then heads home.
Many states have attempted to limit access to abortion after the first trimester, some by banning D&E specifically. Only a handful of these bans have gone into effect, but more and more of these laws are being introduced across the country. This is one of the many abortion access battles that's making its way through our legal system. Now, sometimes later abortions are done using drugs that induce labor. This is called induction abortion, but it's far less common than D&E, and it's even more variable depending on the provider and the precise circumstances of the person who's having the abortion. So that's why you're not hearing about it in detail in this episode. But we are going to talk more about later abortion in future episodes. While later abortions are less common, there are lots of reasons why people need them, and they tend to be the most difficult and costly to access. So now you know what actually happens during an abortion. And remember, if you're still wondering what the heck a tenaculum or a cervical dilator or a vacuum aspirator is, you can see Rob and Marty's photos of some of those things on our website. That, again, is apodcastaboutabortion.com. There's just one more thing I want to mention here. You heard Dr. Shah say several times that abortion is very safe. And I want to give you a better idea of what she means when she says that. One of the most comprehensive studies we have found that the overall complication rate from abortion was about 2.1%. But most of those complications were very minor and easily resolved. Serious complications, the kind that required treatment in an emergency room, happened less than 0.25% of the time. That makes abortion safer than colonoscopy, wisdom tooth extraction, and tonsillectomy. It's also about 14 times safer than childbirth. I want to thank Dr. Shah for being my guest on this episode. We recorded this interview long before the COVID-19 pandemic began, when everything, including my plan for this show, was very different. So I spoke with her more recently about what it's been like to continue providing abortion care during a pandemic. You're going to hear some of that conversation in our next episode, when we dive into telemedicine abortion, the COVID-19 pandemic, and what happened when some states used a public health emergency to temporarily ban abortion. So I hope you'll join us then. Access is produced by me, Garnet Henderson. Our music is by Lily Sloan, and our logo is by Kate Ryan. Special thanks this episode to Addie Henderson, Claire Ty, and Allison Turcos. You can subscribe to Access wherever you get your podcasts, and follow us on Instagram and Twitter @AccessPod. More information and a full transcript of this episode are available on our website, apodcastaboutabortion.com. This is a fully independent production, and if you're able to support the show, I would really appreciate it. You can contribute by visiting glow.fm/apodcastaboutabortion. That's also linked in the show notes. You can also really help out by leaving a rating or review, or better yet, sharing the show with your friends. Thank you, and see you next time.